I practiced as an ER doc at George Washington University. Then I spent 18 years in the totally commercial world, which always fascinates me because clinical people think of non-healthcare related activities as necessarily grubby, which they very well may be, whether that's retail or automotive or otherwise, but is somehow maybe below them. And I suppose that it is, in the sense that it's not taking care of souls and lives and families and children, but a lot of life exists there. And I've always had fun watching where the intersection of motives defines opportunity. And so that's my attempt at being elegant about saying, follow the money. And I like looking at the money, and clinical people don't like looking at the money that much. So as we put specialists on call in the hands of its new owners, this took about 6 months to step back and try and understand what I was seeing happening in connected care and what I was watching happen in healthcare in general. And by no means do I think that this is a pundit kind of speech. I was looking at one really specific area, and that's the advance of consumer-consumed diagnostic or consumer-directed diagnostic testing, which I think is a big opportunity for connected care, and I think it is a trend that will only continue and get bigger. So that's what I'm going to talk about. Because I think people in healthcare today have a very interesting perspective. If you think about this, if we stood outside a Gap store in a mall, outlet, regular mall, otherwise, and everybody walking in the door, we gave them a handful of dollars. And we stood there until they came back out, and 30% of them, 1 in 3, walked out and handed us all the money back and said, yeah, I didn't find anything that I liked. The obvious conclusion that we draw if we were working in the retail space, if we were doing one of those grubby commercial things is that we've got the wrong stuff on the shelf, is that we don't have on the shelves what those people wanted. We gave them free money coming in and they didn't use it to buy anything. They walked right back out. My current focus has become breast cancer, and I think of breast cancer screening right now like the Gap store. 1 in 8 women will get breast cancer if they live to 70 years old. So this is a big deal. This is not a small thing. This is not like, people think of melanoma like a credit card bill. Like, that will never happen to me. It's a low incidence thing. It's way off. And I suppose that's how all of us get through life. But this is the second most common killer of women in the U.S. It's the most common killer of women in foreign countries because they don't get the same level of screening. Yet despite that, 50% of women of color, 22% of women with an advanced college degree avoid getting screened for breast cancer. We raise all this money. The NFL wears pink, the NBA wears pink, everybody wears pink. There are pink ribbons every year, yet women don't go for screening. And that's 22%, of women with advanced college degrees and with private health care insurance. So it's covered. And they still don't go with screening because we're not listening to what they're telling us as consumers. Mammography is the traditional screening test, right? It hurts. And very little has been done to change that. And recently, in looking into this, I looked at the MammoPad. Okay, so it takes the breast squishing device and adds about 1 inch of foam to each side of it. So I took that home to my wife, who laughed and tossed it to one side, right? 'Cause that was designed by a bunch of engineers in a room, and I'll bet you none of them were women. So we're not listening because this is a test that has been painful for 50 years. It's scary. Screening in general is scary. It's got that whole sense of when I walk in and walk out, my life may have materially changed in that length of time, whether that's 15 minutes or 2 hours. It's a horrible process because you go in and say, check me for cancer. And then we do, and then we say, hey, back to you in a few weeks. Back to you in a few weeks. So just kind of hang on to that and deal with the rest of your normal life, and at some point we'll get back to you. Do you know that the average time to follow up of a positive mammogram is 3.5 weeks? So you tell somebody there was something on there. There's something growing inside your chest. See you in a month. And we wonder why the uptake on breast cancer screening is so low. And the recommendations are enormously confusing. And as healthcare providers, we look at all this stuff happening, and we don't really do anything about it. We have academic arguments about whether the appropriate age for breast cancer screening to begin is 45 or 50 or 40. And we argue about that publicly and in the New York Times and the Washington Post as the U.S. Preventative Services Task Force says, oh, it's 50. Then Congress overrides them and says, don't care what you say, you have to start covering mammograms for insurance at 40. So women don't really know where to turn. What they do know is that it's expensive. And it's expensive because they're starting to have to pay for a whole bunch of the costs themselves. And it's very inconvenient because when you go for a mammogram, you don't go in with other screening patients. You get mixed in with the general radiology population. So you'd be there for 2 hours to get a test that's got, 4 shots to it, right? So we're not listening. We're not listening on a bigger scale either, which I think is what's driving where I'm looking now and what I'm talking about today. Think of it this way, Obamacare, whatever you want to call it, the ACA, gave millions of people health care benefits, either for the first time in a minimum of 2 years or the first time at all, and 30% of them, and it guarantees, right, preventative care, with no deductible and no copay, yet 30% of them haven't engaged the system. So it's the gap example, which is we're giving them something that fundamentally they don't want. And they're not using it for that. We're handing them the money and saying, go into the healthcare store and come out with some stuff, and they're coming out empty-handed. They don't have anything they want there. And I think there's a very specific reason for this, because I'm old enough now that that it feels like a long time ago when I was actually practicing medicine. I actually practiced when there was something called indemnity insurance, and we kind of laugh about that right now. But I realized I was in a room full of people the other day who had no concept of health care prior to managed care. So people in my practice experience and patients for years have accepted a traditional healthcare system that fundamentally behaves in a way that you wouldn't accept in any other aspect of your life. But it was free. It was an employee benefit. And maybe you had a little copay. For longest time you had no copays. There was an indemnity coverage, but it was free, so you accepted it. Right? And the healthcare system has always been very patronizing. The smart doctors shift gears with their patients and realize who wants to be in control and who wants to be a participant, who wants to be a collaborator and who doesn't. But when I was teaching, I focused on doctor-patient relationships because I realized there weren't very many smart communicators among the physician community, which is no news to anyone. But the system has always been this way. It's the point of jokes and derision of the system and otherwise, that the communication skills of doctors in particular, kind of the quarterbacks in the provider ranks, have not always been at the top of the range, which is a real shame. But people put up with it because when it felt like it was free, they were recipients of health care. But the average deductible, in the middle of the summer across the U.S. was $1,217, racing towards $2,500 with millions of people having deductibles of $5,000 or more. So, the days of healthcare consumerism being a concept are long past, and it's a full-on reality now. And so people aren't recipients anymore. They are true consumers, and they're spending real money. When you compare $2,500 as an out-of-pocket expense for healthcare to other things that people spend money on, there are relatively few. House, car, insurance, children if you have them. And after that, the list dwindles off when you start talking about $2,000, $3,000 a year. So this is a big deal. This is a really high priority. So they're starting to choose alternatives to traditional care delivery models and to the traditional system. And what I'm seeing happen, I think, is an interesting opportunity for connected care. People are starting to move towards self-directed testing, which I think is interesting. And I'm involved as a long-standing stakeholder in a business that focuses on this area, but we're also seeing it happen in other places. And self-ordered testing is interesting because it lets consumers control the priority of what they're looking for. And that's given over in the typical primary care visit. The typical wellness visit is purposefully not defined because lots of stuff is going to get attention. Prostate, cardiovascular system, skin, and on and on. But consumers, if they're going to start spending their money, they want to spend their money in a very focused way. They want to control the priorities, and they want it to be convenient. So we're now getting into the realm of people commercially offering direct-to-consumer testing, and they're people with an eye towards customer service, so they're making it convenient. they're also making the cost transparent. If you go online to order a lab test, the price is right there. There's none of the fog that exists when you go in for a doctor visit or a hospital visit or an outpatient visit where you really wonder, God, I wonder what this is going to cost me when this is all done. Because no one says to you at the beginning of the visit, oh, by the way, when you leave, you can expect to swipe your card for some amount. You actually go in for the visit, and it's like going downstairs to the casino. You know, you start and think, I wonder where this ends up. It'll be interesting to see. And it's like going to the casino because you usually lose money in the way. And you think about your primary care is fascinating to me because it's enormously anxiety-provoking. I'm in a business right now that is, or I've taken control of a company that is focused on breast cancer screening. And it's got a very unusual technology that will advance the course of this a lot. But that was developed by engineers. And they're extraordinarily clever and reasonably clueless when we talk about patient behaviors because they're thinking about the device. And the reason that 22% to 50% of women don't get screened, a lot of it has to do with the mechanics of screening in the past, but a lot of it has to do with the whole psychology of dealing with the question of, do I have cancer or not have cancer this day, this week, this month, at my current circumstance in life? But when consumers can choose what they focus on, they can modulate how much anxiety they think they can handle at that moment. So they're using diagnostics as their entry point into the system. It allows them to narrow the focus. They can engage the system as much or as little as they want. They can look at testing and screening for diabetes. They can look at testing and screening for hepatitis C. They can look for STDs. Or they can go after the traditional primary care visit, but suddenly they're much more in control. They're able to manage the cost in a prospective way and the anxiety in a prospective way. And the healthcare system is not going to catch up and do this for some reasons I think can be more subtle than might seem. Because traditional care is not structured in a way where you can I'm realizing this is a very bad sentence. It's the first time I've tried to talk about this, so I apologize that. It's structured in a way that you can't take it apart for any number of reasons, but it's very hard to disarticulate a primary care visit into one area. And you could begin with plaintiff's attorneys as one reason for that, because if you come see me, even in the ER, for a primary care encounter, and we talk a lot about your cardiovascular health, but we miss prostate cancer, you know, somebody whose name and face is on a billboard is going to come knock on my door at one point. So it's very hard in the traditional system. It's not structured to deconstruct it. It's not price structured to deconstruct it as well. The traditional system also has been bled dry of resources because good customer service and easy and convenient access to care requires a degree of investment and resource, and the traditional system doesn't have that anymore. It's bleeding from a provider perspective, right? And providers are not adopting remote access technologies like we think they probably could or may benefit from. Everybody in this room obviously is. And all the boys down at HIMSS are pushing technologies all over the place. But I just sat through a meeting with the Orange County, I live in LA, with the Orange County Medical Society. And 96% of the people in the room kind of thought a little bit about this whole telemedicine thing, but you know, it's kind of edgy and I've got to be in the OR at 2 p.m. and off we go. So it's moving and it's making progress, but not nearly fast enough to kind of keep up with what consumers are expecting. And there's pretty good evidence to most physicians that in the course of their practice lifetime, listening to voices of change is not going to have a lot of value to them. So I think a connected care opportunity is circling around this idea of consumer-directed diagnostics, and I think there's evidence that this is an opportunity where connected care really is a tool for progressive healthcare providers to offer service in a different way and to engage consumers who are self-directing. But they want to access the system in a different way. It's their experience entirely that they go see the physician with either they have a scheduled visit, which would be great because it means they're kind of taking a proactive swipe at their care, or they've got a complaint or an issue and they go see them, and that results in a diagnostic test. Did you know that 80% of electronic medical records are diagnostic testing results? So this is a very vibrant part of care. We think about it as an afterthought, but it's a big deal. But that experience with providers is what I call the Jiffy Lube experience. So I'm also old enough to remember when Jiffy Lube started. And I'm old enough, actually, I'm hit that funny point where stuff that I thought was like yesterday was actually like 15 years ago or 20 years ago. My wife looks at me out of the corner of her eye and she thinks, you know, he's losing it. But when Jiffy Lube started, it was great because if you wanted to take care of your car, you went there and you got your oil changed, and it was terrific. And it cost whatever it cost, 29 bucks, and that's what they did. In, out, and off you went. Today, when I go to Jiffy Lube, which I don't anymore, right? I don't engage automotive primary care. Today, when I go to Jiffy Lube, I got to spend 5 minutes making sure the guy tell him I don't want an air filter, a gas filter, my wipers changed, all of the taillights serviced, and any of the other stuff he's trying to pan off on me. I am having a primary care visit for my car. And I don't want you pushing on my car's prostate. Just change the oil for $29, and I have to negotiate my way there. And it's the same thing that's happening in healthcare, and it's why consumers are walking away in increasing numbers, because as the deductible goes up and it becomes their choice, they're not choosing the Jiffy Lube model of healthcare. They're going in a different direction. They have a complaint or a concern, and they now can order a test. And this is, millions of people are doing this, not tens of millions of people, and not the majority of people, but it's a trend that's moving. It's not going to stop. Because they order a test, and based on the test results, then they choose to engage. They go on the web, and I'm actually watching some colleagues develop an issue-based ordering system. So I'm tired. Click on tired. What do I get? CBC, thyroid functions, etc. It's not great, okay? And it's quite intellectually unsatisfying as a doctor, but guess what? If we offer them the Jiffy Lube model, they're not going to engage at all. So we're going to have to acknowledge that it's happening, that it's compromising, but I think connected care is a way to step up and help those customers with what they want, which is an engagement with the healthcare system that they control. They get results back. Most of the online ordering systems will send you results back by email. Did you know that, and I didn't really realize this until I started looking at this, that until HIPAA, there were 23 states where it was illegal to give you as a patient your lab test results. They could go only to your physician. There are still 5. Most people believe that HIPAA regulations, which do allow that, trump those internal state laws. But there are still states, including New York, where it is absolutely against the law for you as a patient to directly get a copy of test results that are ordered on you. And in those states, there is absolutely no way that patients can order their own testing. So that's the kind of thing that drives us even further forward, because we are Americans, and once you take away our grassroots ability to be self-determining, then we start to stand up and pay attention. Consumers want to use the result for provider engagement, and that's why you see laboratory companies now that have telephysician networks on their website. So, I feel tired, I'm going to get the test, and now I want to talk to somebody. And that kind of opportunity for connected care is growing hugely for all of the same reasons. One more time. They can limit the engagement of the system. They want to speak, and they want to address a specific concern. And they want to control costs along the way and set their own priorities. They don't want to engage the traditional provider system if they don't have to. It hasn't evolved the way everything else is involved. They don't want to go into a place where there's an office staff who, in complete fairness, is running faster in the hamster wheel every year to make the same money in that physician's office as they did the year before. And we sit in the physician's waiting room and think, oh, I can't believe I'm waiting for 45 minutes. And they're sitting there thinking, Jesus Christ, we're only running 45 minutes behind. And that dynamic is not going to change. Nothing is happening in an injection of resources for that to change. So that's not going to change. So this way, consumers can engage the system only as much as they want. And they're controlling their priorities now. But also, via connected care solutions, they're giving providers an avenue where a provider can address a single concern. If you speak to me at a distance and say, I only want to talk to you about X, Y, and Z, for a number of reasons, that's tolerable in the connected care environment where it wouldn't be in a primary care visit. I think the model is going to continue to gain steam and win the game because, to circle back to some of my original comments, there's money here because deductibles are only going up. And that means there's just only more control being put in the consumer's hands. And as the deductibles go up, people are becoming more used to evaluating resources online. Do you know the Hispanic community uses online healthcare resources for decision-making more than any other subgroup? That 84% of Hispanic adults in the United States have a smartphone, and they consult that smartphone for 54% of their healthcare decisions. It's a fascinating trend as you look at it across groups. And the more people spend out of pocket, and the more used to they are in directing their own care, rightly or wrongly. We haven't talked at all about whether this is a good clinical idea, but that's really not what's up for grabs in the marketplace. That's what's up for grabs in JAMA and Annals of Internal Medicine and places like that. But in the marketplace where it actually really happens, whether this is a clinically good idea, that's not even a consideration. Those patients don't read those journals. They just have to deal with the deductible. The other thing that's driving this is that the margins for testing providers are much stronger in a direct-to-consumer market. Look at really common things, okay? LabCorp and Quest, the two largest clinical laboratories in the country, huge, multi-billion dollars of tests every year. They barely make any money and sometimes lose money on routine blood chemistry, CBCs, sevens, whatever it's called these days. But they lose money on that, or they break even because they've engaged in these enormous managed care contracts to get volume, and they make money on reference labs, on much higher end testing, hormone levels, thyroid functions, anatomic pathology. But they can barely make money on a CBC through an insurance contract. Hospitals can bill for labs on a special form called the UB04. Hospitals, you know, if you're running at volume, it costs you about 75 cents to run a CBC. And it varies tremendously depending on the size of the lab, but let's just say that it's well less than $1. Okay, so a hospital can bill from $4 to $12 for a CBC, so they're making money on CBCs. If you look online, the average price of a CBC direct to the consumer is $20 or more, which is a lot less than it was 3 years ago. So in the open marketplace, it feels like, oh, the price is coming down. But there's still $20 a margin there versus no margin in an insurance marketplace. Look at mammograms. They're loss leaders for most hospitals. The activity of mammography in most hospitals is a zero producer. It's a wash, typically. Some overtly acknowledge that they lose money, but usually it's a wash. But they do it because they want the downstream procedures. They want CTs and MRIs and ultrasound-guided biopsies, and they want surgeries and cancer care. So they do it. In the open market, across the 48 lower states, the open market price for a mammogram ranges from $300 to $2,100. So where does the provider of diagnostic testing go? They're going to go after the direct-to-consumer market because the margins are much higher. And make no mistake, however much healthcare providers don't like thinking about profit, it's where the power is, because it's allowing people to expand and deliver customer service, become more accessible through geographic but also online expansion. So that's where it's moving, and I think there are some real examples of this happening around us. You've probably read about Theranos in one version or another, which is a fascinating, on a certain level, it's absolutely fascinating, lack of investor due diligence and investing in a company that had a smoke and mirrors technology. But forget that part for a minute. Theranos got all over the news and got a $9 billion market cap because they were going to put lab testing in a CVS. Not an enormously advanced concept, but tests to the consumer with cost transparency vaulted this company to a $9 billion valuation, and everybody from Safeway to CVS making deals with them to do it. You look at 23andMe, little down, but not out. You know, they got a little over their skis with the FDA, but it's a good company with a very interesting offering, and they're back now. And right now they're helping you with your ancestry, but they're getting their FDA clearance to go direct to the consumer, and their valuation is going up because people want to know. They're starting to read about genetic testing. Oop. Hold on. West Labs is a company that I've been involved with for a long time. It's a company that takes hospital laboratory excess capacity. Because most hospital labs after 3 p.m. Aren't very busy, and they take that excess lab capacity and resell it in the community to physicians' offices and otherwise. But what West Labs has realized is that hospital lab capacity after hours is really inexpensive time, not expensive time to run labs. So now West Labs is working with community hospital and academic hospital partners to say, you know what, let patients order labs directly from you. Again, at the $4 to $12 to $20 rate, run them in your lab, and then when they have a positive study, they'll come and see one of your physicians on the referral. So it's a very interesting model. And that's about all I have to say. But I say it because I think that from a connected care standpoint, all of the remotely ordered diagnostics, they provide information, but they're not delivering care. You still need a provider involved if you have a positive test, and I think that's the primary opportunity for connected care in this, is to partner with self-directed diagnostic testing. And I think it really helps consumers address all of their priorities and engage on their own terms. And I think it's a real opportunity for connected care. We're doing it today in my new company. With very interesting results, because we're using connected care to take the time from an evaluation for breast cancer to speaking to a physician from 3.5 weeks to about 15 minutes, and with remarkable impact. So I think that's where the market's moving. We're watching it, we're actively investing in it, and thank you for listening to that for 35 minutes. I hope it was interesting.